Just for disclosure purposes, I am the national PI for the aortic transection trial for Gore and consultant for numerous studies. But today, I'd like to talk a little bit about complex aortic pathology, and you've heard some of it from the other speakers. If you look at the high-risk trial, and this is some of the initial data that we have, it looked at 3 arms of treating patients with complex thoracic aortic disease, and that being aortic transections, aortic dissections, and ruptured thoracic aneurysms, whether that was a true rupture into the chest or aortobronchial fistulas. And so we then compared those groups of patients, 59 total that we enrolled, to literature surgical controls. Now, as I mentioned, there were 3 groups here as we talk about, and from a dissection standpoint, it was acute aortic type B dissections that were complicated. These are not asymptomatic patients. These are patients with essentially malperfusion of one of their visceral vessels or lower extremity vessels. We initially attempted 60 enrollments, and we looked at 30-day mortality and paraplegia and compared it to what was available in the literature. Now, in order to be enrolled in the trial, had to be a surgical candidate over the age of 18 and had to follow the IFU guidelines for the Gore tag device. Now, this is the original device, so it had aortic diameter, intimal diameters must be between 23 and 37 millimeters. You need a good landing zone, approximately distally, according to the IFU, and you need to come back for follow-up and comply with the protocol. Well, if you look at the pathology-specific requirements, a ruptured aneurysm or fistula meant that the thoracic aneurysm was ruptured with acute hypotension, or an aortobronchial and aortoesophageal fistula. If you're a trauma patient, as Scott Stevens talked about, you need a complete or incomplete transection caused by a traumatic event. And lastly, a complicated type B dissection that was less than 14 days old. And this is where a lot of it comes into play. He talked about the INSTEAD trial, but really it's defining it as an acute event with complications of indoor ischemia or malperfusion. And the dissection could not extend into the arch, which means it's not a B but an A. So those are the criteria specific to each pathology. Oops, let's go back one. Now, if you look at the enrollment, we planned 20 in each group, but one of the patients that was in the dissection group wasn't a dissection that was enrolled and later figured out that it was a rupture. So they moved it for that. So this arm had already been closed, and then they moved it to the rupture arm, and so we'd already closed this arm, so that's why it stayed 19 instead of 20. So 59 total. If you look at the inclusion-exclusion criteria, if you look at the patients, where were the violations, and you see here that aortic neck diameter less than 23, five of the patients that were enrolled did not meet that criteria. And this is a judgment call of what you read as the diameter of the aorta. And so the core lab read these as outside those guidelines, but the clinicians during the emergency procedure said it was. And then lastly, you're not allowed to have paraplegia for the transections, but one patient did have that prior to enrollment, and so that was an exclusion criteria and a violation based on the FDA and the IRB guidelines. Now, if you look at the baseline demographics across the trials, a couple things to point out. As you can imagine, the age is lower for the transection trial, transection patient portion of the trial than the others. That's a major difference, but otherwise, a large proportion of males. Not a lot of difference in terms of their range in terms of the upper end, but you see the lower end is much lower for the transection trials in these patient population. If you look at the SVS scoring, not significantly different, but as you notice in the transection trial that an ASA classification of 5 was listed in 10%. Now, this gets to be a little bit of a problem because an ASA classification of 5 is stated that you're not expected to live more than 24 hours with or without treatment. I recently had a case of this. A 30-year-old patient in VA, his only injury was the aortic transection. I listed him as a 5. And that's not the case because once you fix the transection, he's expected to live a long time. So for a 30-year-old, that would actually be probably a 4 in that case. So this is really a problem with the classification is not meant for this particular aspect of things. If you look at the dissection patients, the vast majority had complications of either organ ischemia, refractory hypertension, rupture, or uncontrolled pain. And if you look at the number of these type of complications they're experiencing, over half of them had 1, and 16% had 3 of these indications for getting their dissection treated. Operatively wise, the number of devices implanted, as you can imagine, for transections is going to be very short. 95% only need one, with one patient needing more than one device. Not the case for dissections and ruptures. They tend to need more devices because the lesion treatment length is longer, and that translates to 1.1 versus 1.7. And notice this isn't much different than the clinical trial for the GORE-TAG. About 1.7 is needed. Obviously, the procedure time is much shorter as you have to implant less devices in that particular group. Other outcomes, not surprising, a low amount of blood loss. The ICU stay fairly short. The transections are longer, but that goes to the other complicated problems they have with the multiple injuries, not necessarily just from the transection itself, but still a hospital stay for ruptures 7 days is fairly remarkable. Now, if you look at the 30-day mortality in paraplegia, I really highlight one part, and that's the mortality across them. If you see 16% for dissections, and that is compared to somewhere at around 50% for operative mortality in these patients. Ruptures, 15%, which is quite good, and for transections, 5%. Now, there was one paraplegia in the transection, and there is only 2 reported paraplegia with transection treatments endovascularly in the literature. This was Martin Beck's out of South Florida, so he has one of the distinctions, and I can't remember where the other patient is, but those are only 2, and probably over 3,000 or 4,000 treatments worldwide for this, so it's a fairly rare complication. Now, if you look at the survival for these patients, you see early on, they're fairly good, but there starts to be a separation in terms of the trauma and dissection patients versus the ruptures long term, and the total being obviously somewhere in between. As you get out beyond this time point here, though, the number of patients in the Kaplan-Meier fall off, and they're not as significant out here, but in this area, it's short of the year, there starts to get to be a deviation for that, and this is dependent upon age and other comorbid problems. If you look at device-related events for dissections, you see that ruptured aneurysms, about 10% of the patients had a ruptured component, and that led to issues of branch vessel occlusion, accidentally covered a vessel here, generally the left subclavian for those 2 patients. For the transection patients, the biggest problem was here. Scott Stevens showed you that's luminal obstruction or compression of the device in 10%. And this will lead to some of my later slides as to what's been done about that. And then for the ruptured patients, infection is a problem. If you're going to treat aortobronchial and aortoesophageal fistulas, how do you manage this? And how is this going to be handled with long-term antibiotics versus a temporary bridge and then open treatment later?